May I introduce Professor Arindam from India to talk about congenital debridement and amputation in diabetic foot. Okay, تفضل دكتور أرندام.
Thank you. Thank you very much.
Start,
Okay.
Professor.
So, greetings from India. And you have heard several excellent talks about reconstruction in diabetes. In this talk, we are going to talk about more basic things, debridement and amputation. And I'm also going to present a little bit of an overview of diabetes, which will give us a complete picture. So the definition of diabetes has to be clear to us. The first thing is that it is a metabolic disease. So this is a fairly new concept. And what it means is that it's not just a general condition about the foot, but it's a thing which involves the entire body. And the disease affects how the body metabolizes blood sugar. And we all know that blood sugar is a very basic component of nutrition to the cells all over the body. And if this is not properly metabolized, then we end up with a lot of systemic problems. So it can occur when the body doesn't produce enough insulin, either that or it doesn't use it properly, and it is generally diagnosed when we find that the blood sugar levels are pretty high, by which we mean hyperglycemia. Now, the diagnosis of diabetes mellitus is usually done on the basis of blood tests. Nowadays, it's not that common to present de novo with symptoms. So normally, a person goes for a blood test, and at that point, the person may not have too many symptoms. And then we do a blood sugar, and we find that the normal fasting level is quite high. If it is slightly high, we can call it pre-diabetes. But if it is significantly high, then we have to start treating it as a proper form of diabetes. It's important that occasionally blood tests are, they are incorrectly done. So it's important that two separate tests from two separate labs are done to make sure we are making a correct diagnosis, because once you have made this diagnosis, you have set up this person for a different lifestyle. You have set up this person for a lot of medicines, maybe surgery. So it's an important diagnosis which you should not miss, and yet you should not overdiagnose either. Yeah. So this metabolic disease affects all systems of the body, the heart, the brain, the legs, because it causes changes in the blood vessels, and it leads to macrovascular conditions. So in the musculoskeletal, it can affect the major arteries, it can cause deposition of lipids, and it can cause small blood vessel disease as well, like problems with the eye, with the kidneys, and even with the nerves. It also has other generalized systemic involvement, like involving the GI tract, the pancreas, of course, and it can even cause increase of simple conditions like a frozen shoulder. We see patients in our clinic with frozen shoulder, and if you look back, you might find that many of them have diabetes. Similarly, skin, we have a lot of skin lesions. You see a lot of superadded infection, yeast infections, etc., which can be a warning sign of high blood sugar. Now, let's go to the musculoskeletal system. And a foot is a part of the body which is normally involved. The reason the foot is involved is that we all know that the vascularity of the body decreases after the mid tibia. Lower tibia is an area where the blood supply is not great, not fantastic. It's not as good as the hands or the forearm. And foot problems initially start with changes in skin color, with a low temperature, dry, cracked skin, loss of feeling or altered sensation, an inability to sense heat or cold properly, which leads to burns in diabetics. This is very important because often we have patients we send for physiotherapy from our general orthopedic clinic. And if we know that they have diabetes, we have to be careful they don't get burnt while doing a wax bath or taking some kind of heat. Often we see thick yellow toenails, loss of hair on the toes, feet, lower legs, fungal infections, ingrowing toenails, blisters, ulcers, infected corns. And of course, there is swelling of the feet, and you might see foot odor from some infections. Another thing to remember is that many of these patients are smokers, which is an added insult on top of diabetes. So if you have a diabetic who is a smoker, your antennas have to be really focused. Now, for diabetics, even before we start any kind of medical treatment, the patient should be involved in his or her care, just like ladies are advised to do self-examination of their breasts. Similarly, diabetics should be warned to look at their feet daily, especially in the evening or morning, and use a mirror to look at the bottom of the feet because, as I said, there is altered sensation. So they may have an ulcer, but they may not know that. They should feel the surface of their feet for lumps, bumps, blisters. They should feel their pulses, fundamentally two pulses, the arteria dorsalis pedis, which is in the middle of the ankle, as well as the posterior tibial pulse, which is just behind the medial malleolus. So a diabetologist should point out that these are the places you can feel your pulses. And then after they've done all the self-examination, they should wash their feet properly with warm water, dry them very carefully, not leave it wet. And then occasionally apply a moisture. This should not be a very strong moisture, but it should keep the feet moist. But again, you should avoid keeping the feet wet. So you have to make sure they're not dry, but they should not be too moist either, because if they're too moist, it can lead to further problems. They should always wear well-fitting socks and shoes. The shoes should not cut into the feet because these can cut into, cause ulcers. And it's important that when going barefoot, which is very common in our country, they should be careful that they don't get thorns or stones going into their barefoot. So it's better these patients avoid going barefoot. So the problems that a diabetic has in the feet are usually due to neuropathy, which is nerve damage, or due to reduced blood supply. This blood supply reduction can be both ways. It can be macrovascular, by which I mean that popliteal artery onwards, the vessels, the anterior tibial and the posterior tibial, they may have reduced flow due to changes in the blood vessel lumens, or these problems can be microvascular. And often, I remember when I went for my fellowship, one of the things we were taught in diabetics was that you should see the pulses, feel the pulses, but often you might have an ulcer or ischemia in the presence of proper, pulses, because it also is a small vessel disease because there is a microvascular insult. Now, these problems can lead to foot ulcers, they can lead to infections, and in severe cases, amputation, which we will subsequently discuss. So these are the gradings of diabetic foot ulcers from grade 0 to grade 5. So grade 0, just like a very mild abrasion. Then in grade 1, a superficial ulcer. In grade 2, a deep ulcer. In grade 3, the bone starts getting involved. There may be infection and an abscess. And here we've written osteitis because the bone may be inflamed. And then gangrene can set in the toes, in the forefoot, and eventually it can extend right up to the entire foot. So these are demarcated as grade 4 and grade 5. At this stage, the problem is irreversible and amputation is the only option. Now, like most things, and especially metabolic diseases such as diabetes mellitus, the treatment has two components. The first component, of course, is conservative management, by which I mean that you have to control diabetes mellitus with appropriate drugs, either with insulin or with tablets. And in addition, you need to, of course, when there is a sign of infection, you might need to give local antibiotics or more commonly systemic antibiotics. This could be in the form of tablets, or it could be in the form of IV injections, but it's important to treat infection early. In addition, the idea of offloading these ulcer points with custom-made orthotics, braces, these can relieve pressure and help the ulcer heal. And of course, there are dressings. Now, why are dressings done? Well, they're very important in diabetes, and the dressings are to prevent tissue desiccation, by which I mean tissue drying. And again, it has to absorb the excess fluid. So it should not be too dry. It should not be too moist. Too much moist will lead to problems. Too much dryness will lead to problems. So you need to do a dressing which hits the middle ground. You have to protect the wound from contamination because you don't want external agents getting in. And some of the good dressings which are used are alginate dressings, which are formed from seaweed and can absorb moisture and form a gel, which supports the healing of the foot ulcer. Or you can use foams, which again act as a secondary dressing to absorb more moisture. The other thing is that, of course, you should wear good shoes and proper socks, as discussed, so that the loading of the joint is appropriate. Now, there are many types of treatment of diabetic ulcers. We will not discuss everything here because a lot of it has been discussed in the earlier chapters. We are going to talk about debridement, which is the procedure which removes dead or infected skin and tissue from the wound. So if the tissue is dead, there's no point trying to save it. You need to excise it because the dead tissue always acts as a nidus, it does not allow the wound to heal. Then, of course, there are plastic surgical techniques which are used for persistent non-healing ulcers. Podiatric surgery, which is deformity correction. We've discussed some of these. Hematos, bunions, high arches, flat feet. Vascular surgery, of course, if you have a proximal lesion, a lesion of the blood flow, of course, you cannot do local treatment without treating a vascular surgery. So you might need to clean up the vessels higher up, or you might need to bypass them. In addition, if there is an infection, you might need to do an incision and drainage, might need to do some form of tissue revascularization. The healing of these ulcers depend on a variety of factors, including where the wound is, the location, the pressure on the wound, types of swelling, circulation, the glucose level, and wound care. And this healing is not a one-day matter. It may take weeks or months, or it may never heal. Uncommon procedures are, I would not say uncommon, but they are less common than the procedures we have discussed. And they are things like relieving, unloading the pressure on the ulcer, such as tear lengthening, or maybe removal of the head of particular, say, the metatarsal to relieve pressure on the ulcer. So if you see that there is a piece of bone which is rubbing on the ulcer from inside, until you remove the offending bone, it is unlike the ulcer to heal. But once you remove it, there is a chance that the ulcer will fill in and things will get better. So nowadays, among the surgical treatments which are available, we have VAC. So you can do VAC of the lesion. You can put these bandages. In India, we have a lot of technicians who become VAC specialists, and they even go to the house of the patient and they apply VAC. And then after the wound is healthy, the wound can be grafted. Similarly, there is debridement and grafting. By debridement, you've seen how it can be done. You can do it with ultrasound, but normally we do it with a knife and a forceps. We just see which is the tissue which is unviable. We excise it, and it's important that we don't leave any dead tissue behind. It's important that we are a little bit ruthless, because unless you are ruthless, you are unlikely to get healing. And having done that, then you allow the wound to granulate, and later on you can proceed with skin grafting. So these are some of the issues. Now, these are common lesions which we see when you have, let's say over here, where you have a particular toe which is infected. Of course, this toe cannot be saved. Most of the cases, you might need to just take it out and close the lesion, like here, over here. So selective toe excision is important. In some cases, you might be able to sort of avoid doing larger surgery. And occasionally, if you have, I've not tried this technique, but I saw it while reading up for this. And you can even put bone cement beads, which have antibiotics, so you can clean up, do a ruthless debridement, and then you can put in beads, let the wound heal, similar to changing, doing revision hip surgery or doing revision knee surgery. So you can use the beads, and it's relatively easier here to just take it out and then clean up and do a reconstructive procedure. Or like here, you can, two toes have been lost here. Again, this wound has been closed, and debridement and amputation of the toes have been done, leaving a healthy forefoot. So if all that fails, then there's no point leaving, if you've lost your big toe and you've lost a few fingers, often there's no point trying to keep two toes, because those toes will, just keep on bouncing on hitting things and leading to further ulcers. And, one of the causes we do amputation is that it's called dead dangerous and damn nuisance. So damn nuisance, if you have just two toes sticking out, those toes are going to hit everything in the room, and patient will have frequent pain. So in such a case, the entire forefoot in this case has been removed. Here, the big toe has been shortened. In this case, if it's a toe in the middle, you won't miss it so much. This is an operation I've done a lot of times, and just you disarticulate the joint, and you can just close it here. And by closing it, you keep a gap, and with that gap, the shape and size of the forefoot is maintained, but the toe is, which previously was a problem, has been lost. So these are various types of things which can be done. Again, we've discussed this. Now, one of the things, I have worked in the West Indies for a while. I actually used to work on a very small island called St. Vincent and the Grenadines. And at that time, this is nearly 30 years ago, the population of that island was 350,000 people. So if you have a population like that on an island, then you have a lot of intermarriage, of course, because there are only 350,000 people to choose from. So if someone has diabetes, diabetes is a genetic problem. It spreads between different generations. So, ultimately the entire population can get infected with diabetes because they're marrying within the community. And we used to do a lot of amputations there, because the patients used to come rather late, and they often had a lot of gangrene. So there was no scope at that stage to do reconstructive surgery. So in addition to reconstructive surgery, we used to do a lot of amputations. But one of the things that we discovered was that if you do a bit of amputation, again, they come back and there's more gangrene, you cut a bit more, and again, they come back with a bit more and they cut a bit more. So you keep on doing, like a salami, you keep on cutting more and more. So we found that often people don't want to have surgery every year, and they get depressed, cutting bits of their foot, and then half the time they, cannot walk around. They don't have a prosthesis because, again, next time they come for some more surgery. So we found that the most stable option in such cases is to do below knee amputation after once or twice. Just go and do a below knee amputation. I think I'm going to talk a little bit about below knee amputations, because that is something which we do a lot in these patients. So I'm sure there are lots of trainees in this audience, and I was told that there would be a lot of trainees. So I think this is a operation we need to discuss it a little bit, because this is something you will have to do a lot in your practice. So there are a few things I want to highlight. The first thing is, when you do this amputation, of course, you need to take consent. In India, we've always had this system that two surgeons have to consent. So it's not, if you want to cut off someone's leg, you first have to talk to the patient, you have to talk to the relatives, make them agree, and then you have to write down that this is required, and then another colleague, surgical colleague, will also have to see the leg independently and then also write down that yes, amputation is, there's no option but to do amputation. If you don't do this, in 2024, you might get into a lot of medical legal issues. So be careful and take your consents. You mark your flaps before surgery. Now, when you're marking your flaps, make sure your posterior flaps are longer than the anterior flaps. So you can see here, and the reason for this is the calf muscles are, the gastrocnemius and the soleus are at the back. These muscles have a better blood supply than the anterior part of the tibia, which is really basically periosteum. So you need to take more tissue from the back, and you need to cut the mark out the flaps. Also, you need to mark out where you are going to do the amputation, at what level. And when you're doing this, it's important to remember that you are cutting the bone higher, the muscle lower, and the skin the next level. So you should cut it you should mark and know how much you're cutting. And there is this concept of what is called ideal amputation length, 15 to 20 centimeters from the knee joint. But nowadays, the prostheses have developed so well that you don't necessarily have to stick to that guideline, but it's a good guideline to follow. But I would suggest is that you talk to the orthotist before you do the amputation if you have an opportunity, because they can give you a good idea. Now, when you are cutting the bone, you have to, I won't go into the steps, but just the highlights. When you're cutting the fibula, apart from the tibia, make sure you cut the fibula at least 1 or 2 fingers, maybe 2 fingers above the tibia. The reason for this is if you cut the tibia and fibula at the same level, then when the wound heals, the fibula can spring back and come out of the wound. So that will be very awkward for you later on. So you will again have to revise it. So make sure you cut the fibula a little higher. And when you're doing the arteries, again, the arteries will not have a very good blood flow in diabetic patients, but make sure you locate the arteries properly and you transfix them with sutures. Make sure, I often do that at 2 separate levels, because again, if it slips, it will bleed post-operatively, and you don't want that. When you are ligating when you are tying the veins, simple tie will be sufficient. When you are doing the nerves, make sure you have a sharp 11 size blade and you cut the nerve very carefully with one single stroke so that there is minimum trauma. After that, do meticulous hemostasis and drainage and put a protective POP, and make sure you talk to the orthosis company early. So I'm going to summarize now and all the lessons which we have discussed. The first thing is that diabetes mellitus is a dangerous metabolic disease. The foot is the least it's the least problem. Okay, the other problems are kidney, the eyes, the heart. These are the things which cause death, and it causes 9th highest death mortality worldwide. So it's very serious. 9% of Americans have it, though not some of them are still undiagnosed. You can see this curve here. You have total diabetes and you have diagnosed diabetes and undiagnosed diabetes. I'm sure in India, in Egypt, undiagnosed is very important, and we don't know about many cases we are dealing with. But so we have to have a high suspect, we have to be careful about this. So this disease is high in developed countries, but it is rising very fast in poorer parts of the world like ours. So India is considered the diabetic capital of the world due to a combination of genetics, poor diet and lifestyle, smoking, inactivity, which is a big problem. But we also need to remember that actually I always thought that India was the highest, but if it's not, actually I found the figures for China are higher. So they have similar problems. And we have about 77 million have documented disease, 25 million pre-diabetic. But I'm sure if we did a survey for India, we'd find that undiagnosed is also very high. Diabetes is very common in societies where consanguineous marriages are allowed. Luckily, in our society, it's not very common. But those societies will allow you to marry your first cousin. It is an issue. Isolated societies which have small populations, as I discussed in West Indies, small islands, it's a big problem. 15% of diabetics develop food problems. These food problems can be treated with a combination of medical, surgical problems, drugs, debridements, dressing, vacuum-assisted closure, and of course there is reconstruction, which has been discussed in earlier chapters. Amputation can be done if the above measures fail. Sometimes the patient also presents late. Remember, every case of diabetic foot is different. Every ulcer is different. You have to think about the problem closely before you come to a solution. And when you do an amputation, if you decide to do an amputation, please make sure you consent properly to avoid medical legal problems. It should be done technically correctly, and an orthosis should be applied early. Thank you very much.